Hey, it's Professor Kristen. And so one of the things I want to do today is do a pharmacology test review. This is geared for my students, and we've been talking about antihypertensive, antianginals, and also some heart failure drugs. This is a very beginning piece of this. And so I want to just jump in, do this quick test review. I think it will be not only helpful for my students, but can be helpful for you too. So let's get started. So let's review. There's a lot of words on here, but I want to just start with number one. When we're reviewing, remember nitrates vasodilate. They'll lower your blood pressure and they're going to decrease the workload of the heart by dilating. So when we open those vessels up, blood flows easier through, the pressure is decreased, lowering that blood pressure, and that will decrease the workload of the heart. The one thing I want to make sure that you understand about nitrates is that it is a systemic drug. When we give that, it's going to dilate everything. So we have different side effects that happen with nitrates, and that is all geared to this vasodilation. When giving nitrates too, don't forget that we need to monitor these patients or clients. We need to monitor their blood pressure. If they are taking them at home, they need to monitor themselves. So it's very important. Number two, when applying patches and cream, nitro, we're talking about nitrates, always rotate your sites. I'm not sure the English on that, always rotate site. I was typing quickly, but I do want to just go ahead and say any patch or cream, guys, if you're putting it on skin, you don't want to keep putting it on the same place over and over and over again. They're going to break down their skin. But for nitro and nitroglycerin paste or patches, make sure that you rotate the site. When you peel off, make sure you gently cleanse the area and pat it dry. Don't be rough on that skin area. If it's a cream, make sure that you cleanse that too, gently wiping off and cleaning and patting dry. Be gentle. Also, guys, for nursing, when you're touching any of this, any of these medicines, any of these creams, patches, taking them off, whatever, make sure that you wear gloves, because if it gets on you, you're going to have a little dose of a nitrate yourself. So we don't want that to happen. There are steps. Remember to review your steps when teaching a patient how to take nitro sublingual. If they're having chest pain, the first thing they need to do is stop, sit down, or lie down, because any extra work demand on the heart is going to increase the oxygen demand, the workload of the heart. And if they're actually having a heart attack or an acute myocardial infarction, they need to stop expending the energy. They've got to sit down or lie down. They can take their first dose of sublingual nitroglycerin. If they have no relief after 5 minutes, they need to immediately call 911 and take a second dose sublingual. They might feel a little burn under the tongue, means it's working when it goes under the tongue. And that's important to know. They can then, in 5 minutes, if they're still having chest pain, even a twinge, they can take the third dose of nitroglycerin sublingual. And that is the last dose that they're to take. They can take 3 doses in a 15-minute period. But after that first dose, if there's no relief of chest pain, or even if they're still having some chest pain, they need to call 911, because it is possible that they're having an acute myocardial infarction, and time is tissue. We got to get them through that ER, get them to the cath lab. Another thing I want you to remember or know is IV nitroglycerin. If we're getting IV nitroglycerin, there is specific tubing that we use. The packaging on it, if you read it, will tell you it's probably nitroglycerin administration tubing. It usually labels it, but it is a non-PVC plastic, and we normally continue to give nitroglycerin in the glass bottle form. If you are using nitroglycerin and you need to put it in a bag, if someone's mixing it in a bag, the pharmacy or whatever, it needs to be in specific plastic for that too, non-PVC plastic. So usually you see it in a glass bottle, and that's why. And then we use the non-PVC plastic tubing. It's a need to know. Also, tolerance. If they start to have tolerance, this is a medication, nitrates are medications, nitroglycerin, that they can become very tolerant to. And that means you can't increase the dose. But what we can do is at night, have them take off their patch or their paste and leave it off overnight while they sleep. First of all, the body is resting. We should not be in an increased demand for oxygen to the heart. Usually it's a time that they won't have chest pain. And then in the morning, get up and put the paste or the patch back on. That time frame of rest in the night will help the body to kind of reset itself so that they won't have that tolerance level. And so when they put it back on in the morning, they should get the effect of the nitro. Always review your different chest pains. It doesn't matter. There's classic, variant, unstable, and Prince metal. Those are identified in the actual nitrate video. So if you are interested in that or need to know that for my class, go back to that video, please, and rewatch that. Which medication causes constipation? This is a biggie. You will see this on NCLEX, guys. This is a calcium channel blockers. They cause constipation. We need to tell our patients that, but the question is what do you do? Well, first of all, you want to tell them to drink plenty of fluids if they can. If they're a heart failure patient, they will not be able to increase their fluid intake, but they can increase the fiber in their diet. They can do stool softeners, and of course, being mobile, getting up, moving around. Those things can help. Always think, what will the nurse do? And you'll never go wrong. The next is beta blockers. I want you to know that they can mask hypo and hyperglycemia. This is huge. So you have a diabetic that's taking a beta blocker. We need to explain to them that this can happen. It can mask this hypo or hyperglycemia. So we need to check blood sugars if they're in the clinic or hospital setting with us. And if they're at home, they need to know and understand that they need to watch for signs and symptoms and also check sugars because it's going to mask it. They're not going to see it or feel it. So we need to make our patient aware. Adverse effects of beta blockers. I think it's really adverse effects of nitrates, beta blockers, all of them is we can be hypotensive, number one. But for beta blockers, we're going to lower our heart rate. They affect the beta 1. Beta 1 is heart, beta 2 is lungs. So when it affects the heart, it can create bradycardia. So because of that, we need to make sure we monitor our heart rate. And if we are under 60 or less, we should not give the drug. We should hold the drug and call the doctor or the physician and let him know what we're giving and what the vital signs are. Once again, the adverse effects of beta blockers is bradycardia. Hold if your heart rate is 60 or less. And when you do hold any medication, always know you need to call the doctor or physician and let them know. And then document that you did, because you need to either get another order for something, or they might go ahead and tell you to give it. You know, this patient lives at this heart rate. That happens sometimes. But as a safe practicing nurse, if you have bradycardia, if you have a heart rate of 60 or less and are bradycardic, that do not give the beta blocker, because you're only going to lower the heart rate more. Lowering the heart rate, you're going to lower the blood pressure. Remember to review beta blockers and what they do. Beta 1 is for the heart, beta 2 is for the lungs. I went over that in the video with beta blockers. So if you go back and review that, that would be a great thing to do. Not a big in-depth. Next semester, we'll go more in-depth and get real deep and dive into all of that. But the base understanding of what a beta blocker does. Okay. Let's review. What is the antidote for digoxin? Well, it's Digifab. So if you become, if a client or patient becomes dig toxic, they can receive a medication that's the antidote. It's going to help stabilize the heart rate for the patient. And as the patient gets rid of the digoxin, the toxicity. What are the signs and symptoms of dig toxicity? The number one sign and symptom of dig toxicity is the halos around lights or visual disturbances. If you have a patient or client that says, hey, you know, I'm having trouble seeing my vision. It's weird. Everything looks weird. I look up at a light and it's got like this little ring around it or has a halo type thing around it. It just looks different. That is a sign of dig toxicity. Also, bradycardia is another sign. Also, if the serum potassium levels are high, another sign. So review your signs and symptoms of dig toxicity because you need to be able to identify it. And then if they do have it, you would call the physician, draw some labs, take a look. And then on top of that, they would probably order Digifab to be given so that it can counter that dig toxicity. It's important. What are the first lines of drugs for heart failure? ACE inhibitors, we like them. ARBs and beta blockers. These three things are the first line drugs of heart failure. One of the things that I explain in heart failure, though, to my my students is ACE inhibitors. So go back and look. If you hear a ding, 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 make sure you focus on that in that video. And, but you could get a question that asks, what are the first line drugs for heart failure? Well, we want to give it, we can and give ACE inhibitors, we can give ARBs, and we can give beta blockers. But we just need to know what each of these drug choices, ACE inhibitors, beta blockers, what they do and where it can be better or worse for a heart failure patient. But I went into a lengthy lecture in class on heart failure. So please follow your notes on that. ACE inhibitors, captopril and lisinopril, are pro-drugs, so they do not metabolize in the liver. This is important because all of the rest of those ACE inhibitors do. They metabolize in the liver, and by metabolizing in the liver, that means there is a breakdown. And so you can have, they take it by mouth, and then it has to, if it's a prodrug, they can take it orally, but it will not do or have the effect unless it is, the bioavailability is there and it breaks down within the system. And so captopril and lisinopril do not have to have that. They work. You can take it and it works. So I just want you to be aware of those two drugs that are not prodrugs. It's something to know. Captopril, lisinopril. Remember, the prils are your ACE inhibitors. Those two specific drugs are not prodrugs. I just wanted to make you aware. Nursing implications, review what you need to do for your clients and patients always. Remember orthostatic hypotension or postural hypotension. If you get a patient up quickly, they can have a drastic change in blood pressure, become hypotensive, and pass out. So it is a safety issue. How do you set patients up? What do you do to get a patient up so that they don't have orthostatic hypotension? How do you educate a patient going home what to do so that they don't have orthostatic hypotension? We'll want to set them up on the edge of the bed. They can pump their feet, wait for a few minutes, stand up. Don't try to get up and run, get up and walk quickly. Just stand up, stand there for a few minutes. Let your body acclimate and regulate so that you don't have orthostatic hypotension. Always vital signs, guys. You need baseline vitals. If it asks you for anything, what should you do first? You should get a set of baseline vital signs. If you're having any issues, we need to know what's going on. Are they bradycardic? We can correct that. Are they hypotensive? We can correct that. So we want those baseline vital signs. We need to know. Also, weighing a patient. Remember the steps to weighing a patient. Same time, same scale, same clothing. Have them get up in the morning and go to the restroom first. Most people do that. We wake up and we go to the bathroom, don't we? It's an immediate thing we do. We want to go and use the restroom. Let the client or patient tell them to go do that, and then make sure they get on the same scale around the same time. It doesn't need to be exactly at 8 o'clock, but close. They don't need to weigh themselves at 8 one day and tomorrow at 2 p.m. There's a big difference. So we want that morning weight, and then they should go from there. Also remember, if they gain 2 to 3 pounds in a 24-hour period, that is water gain. That is, we're looking at heart failure patients. When we have that, that's important to know. They'll need to call their physician immediately because they are becoming fluid overloaded. So it is so vitally important that they watch that after they weigh themselves, to write it down and monitor. Bring that paper with them to their physician's appointment so they can review those numbers. But if they have that 2 to 3 pound weight gain, or if they have a 5-pound gain in a week, that needs to be also called to the physician. That is not good. Okay. So go through nursing implications. I talk about them in the 3 videos I posted. Go through again, listen again, write them down and review them, because it is so important in nursing school that you realize you've got to learn all this information, but then you've got to figure out, what are you going to do as the nurse? Because that's the bottom line. What are you going to do to help the client or the patient? Also, don't forget your dietary information. I talked in detail about that in class also. You remember, no salt. If they are hypertensive or they are a heart failure patient, no sodium. Wherever salt is, water will go. So if you eat a very high salty diet, you're going to retain fluid. Also, there are other things that we should and should not eat. And I went over those pretty thoroughly. And please review those for testing purposes. Remember, nitro loses its nitroglycerin tablets if they're in the little bottle, or nitro in a bottle. All nitro will lose its potency. Sunlight is a kicker. Sunlight will break it down. So it's usually in a dark glass bottle with a screw top lid. Once that's open, the tablets, its potency is good for about 3 months. So you need to let a patient or client know that, because they might not take but one of those little pills out of that entire little bottle. And like a lot of people, they don't want to throw it out because they have so many left. So it is so important that you tell the client, sorry, once you crack that lid and open it, it's good for about 3 months. Use it or not, it's only good for about that time frame. They'll need to have another bottle available. They don't need to get rid of anything until the new bottle is in hand. And so, but they should prepare to get that new bottle. If you're giving IV nitro or nitrates, when they're hanging, it is so important. They come with a little, you'll get a bag that's like a brown bag. It is important to use it because it does break down in sunlight. So what you do is you can put the bag over and protect it. It is so vitally important that we do that. If you heard a ding ding in my lecture videos, please review that information. That is so important, especially for my students. If I'm dinging it, it means it's something you really need to know. Write it down. I say formulate your notes. I know people are trying to kind of get away and do these fast, quick things, but I'm telling you is you need to read, listen to the video lectures, write notes, and then go back and put in even more information. Something that was in this that wasn't covered in the video, make sure you go back and take a look because it's so important. And the next thing I want to say to you guys is you've got this. Study, break it down, look at those videos. They're going to help you. And then look at this review. I hope this helps. See you soon.